listening. So we do Google Forms, and like so the person who just joined will be making the Google Forms.
Got it.
Yeah. Okay, so we're live. We'll just give it a couple minutes. We do Google.
And I have all my contact info at the end, by the way. So like,
yeah, perfect. Yeah, and then we'll also like it'll be available on our Instagram as well for everyone.
Okay, cool. You said about 45 minutes. Or how long should I talk for?
Oh, you can like 45 minutes to an hour.
Okay. I honestly have no idea how long. I could like talk about this for days. So
yeah, like
not that long.
Try to like cap it at an hour.
Right. Okay. Because I like it could be really short or it could be really long. I'm not sure.
Yeah, no, you're totally fine. Yeah, usually people take up to like an hour, so that like, yeah, we usually say like.
And I'll leave time for questions.
Yeah.
Okay. You'll tell me when to start.
Yeah, I'll just introduce you. We're just giving it a couple minutes for a couple more people to join.
Yeah.
Okay, so we can begin. Welcome everyone to today's shadowing session with Rebecca Jaspan, who is a registered dietitian, and she'll be talking about nutrition for eating disorders today. Welcome.
Thank you for having me. Okay. Okay. All right, so just a little bit of an introduction. So I am a registered dietitian. I currently specialize in eating disorders. So I see clients with anorexia, bulimia, binge eating disorder, as well as clients with orthorexia, disordered eating, and those who want to take a more intuitive eating approach to eating, which I'll talk about a little bit later. I also specialize in sports nutrition, and I love sports nutrition too because a lot of athletes have eating disorders. So I love working with those athletes who might be under fueling or having issues with their food and body. I'm also a certified diabetes care and education specialist, so that's a certification that I have. So I also specialize in diabetes. I work in private practice with Laura Sapulo Whole Nutrition and Yoga in New York City. And I help people improve their relationship with food and their bodies through education on the basics of nutrition, mindfulness, and body kindness. So a little bit of background about how to become a registered dietitian. I don't know if there's any future RDs here today, but it's a long course. You do a program, undergrad or master's degree, an accredited program. We take courses in biochem, organic chemistry, biochemistry, nutrition, and metabolism. So it's basically like a pre-med undergrad or master's with a little bit some differences and some additions. And then we do 1,200 hours of supervised practice, which is basically like a 1-year residency where we get experience. And then we sit for a licensing exam. And then we have to do 75 hours of continuing education credits every 5 years to keep up our license. So I did my undergrad in nutritional sciences at Cornell in upstate New York. And then I did a master's of public health at Hunter College in New York City. And then I did my dietetic internship through Hunter College also in New York City. So a little bit of background about my career path. So I went from my internship straight into the clinical world. I did a few years of inpatient nutrition counseling, and then I got my diabetes educator certification and went into an outpatient setting in a hospital. And then about a year ago, I made the transition into private practice. I kind of always knew I wanted to be in private practice. And I found eating disorders because, so I worked in a low-income population, a lot of diabetes, a lot of weight loss. And what I noticed is a lot of people would come in very confused about nutrition, not knowing what to eat. A lot of people coming in for weight loss, afraid to eat a lot of foods, diabetics, told maybe by their doctors or other healthcare professional that they can't eat fruit, very afraid of a lot of foods. And it was very difficult for me to help these people when they were afraid of so many foods. There was also people on a ton of diets. So like all that weight cycling will mess up your metabolism. So I really, became more passionate about helping people with eating disorders and disordered eating. And so for me, so much more rewarding. And then private practice gives me a lot of variety, a lot of flexibility, and a lot more reward. So I find that, someone will come to me and tell me that they, enjoyed a social situation without being stressed, or they were able to eat a food that previously they were afraid of, right? That's so much more rewarding to me than someone coming and telling me that they lost 5 pounds. I already see a lot of questions. Should I start answering them?
You can answer them whenever you want. If you want to answer them at the end, that works too.
Let's see if there's anything that, Okay, I'll get to that. Okay, let me get into it a little bit more, and then maybe some will be answered along the way, but these are really good so far. Okay, so a little bit about a typical day for me. So I'll see my clients, and then I'm always meeting with the team members of my clients. So pretty much all of my clients have at least a therapist, and then they may also have a psychiatrist and a medical doctor. And it's really important that I communicate with those people. So I might be setting up phone calls or meetings with them. We write blogs for our website, so I'm writing blogs. I also write for an online publication, so I might be working on that. And then just like any healthcare professional needs to stay up on current research, I'm always reading, doing research, keeping up to date, always learning. My work hours really vary. They could be anywhere from 8 to 12 hours a day, about 45 to 50 hours a week. I pretty much work 6 to 7 days a week. Might not be like a full day, like on the weekend, but in private practice, there's pretty much always something to do. So I like being very busy. I also like that I can, that I have control over my hours for the most part. I also work from home, which I recognize is a huge privilege. I also really like it. I know other people don't like it as much. And I do go into the office 1 day a week to see clients in person. We also do meal support therapy in our practice. So we eat with our clients. We will go out to restaurants. We might order into our office. We'll do virtual meal support too, just to offer that extra therapy and support around the meals. We do a lot of cognitive behavioral therapy at those meal supports. So that's a really fun and great addition to the practice as well. Okay, so I just want to give a little bit of background on eating disorders. I know that nutrition is covered very minimally in nursing school and med school, and I don't know how much eating disorder information you get. So I'll go into it a little bit. So eating disorders are a serious but treatable mental and physical illness. They don't discriminate. They affect people of all genders, races, religions, ethnicities, sexual orientations, body shapes, and weight. About 20 million women and 10 million men in America will have an eating disorder at some point in their lives. And there is a higher prevalence in BIPOC and LGBTQ communities, and often those people also go undiagnosed. Eating disorders are caused by a combination of biological, psychological, and sociocultural factors. So there's definitely a genetic predisposition. You can kind of think of that genetic component as like the wood, and then there might be a spark that sets off that fire. So someone else might be predisposed to an eating disorder and never actually develop one. There's strong evidence for people with history of dieting will develop an eating disorder, and then also type 1 diabetes. Research shows that women, especially with type 1 diabetes, are at higher risk for developing an eating disorder. And then psychological aspects. So being a perfectionist is huge. Any body image dissatisfaction. Often, there's a lot of psychological disorders that are co-occurring with eating disorders. So like anxiety, OCD, borderline personality disorder, any kind of disorder of over control, this like rigid personality. And then sociocultural factors. So weight stigma is a major risk factor. Any bullying that people might have had at a young age. This internalization of the ideal body. So unfortunately, we live in a culture that values white, thin people. And so, and then people have also this acculturation, people have also really changed their cultures to kind of adopt this white, thin ideal. Social media, as we all probably know, is very toxic. And then any history of trauma, sexual trauma, emotional trauma, any traumas can are often people develop eating disorders. Quick overview of the different types of eating disorders. So anorexia is you see weight loss or a difficulty maintaining an appropriate weight, an intense fear of weight gain, distorted body image. There might be food and calorie restriction, and we might also see compensatory behaviors, whether that's purging through vomiting or laxatives or exercise. Eating disorders or anorexia is often diagnosed in adolescence, so adults can present with it. I once had an 82-year-old in my office with raging anorexia, and it can affect all body types, and larger bodies often go undiagnosed. Bulimia is a cycle of binging and compensatory behaviors, so it could be, again, purging through vomiting, laxatives, or exercise. And to be diagnosed with bulimia, these behaviors have to occur once a week for 3 months. And then binge eating disorders are episodes of eating large quantities of food, feeling a loss of control during the binge. So like if you're ever assessing for binge eating disorder, a good question to ask is, once you start, do you feel that you can't stop? And always followed by feelings of shame and guilt. And I put the definition of binge here because people kind of throw around that word a lot, and don't really kind of have like what's like the clinical definition of it is. So it would be eating 2 hours, so in a short period of time, a larger than what we would consider a normal amount of food. Always with a lack of control, often with a lot of like disassociation, eating more rapidly than normal, eating until uncomfortably full, maybe not physically hungry at all. And oftentimes these binges happen while the person is alone. And also it has to occur at least once a week for 3 months. And with binge eating disorder, there's not a compensatory behavior. And then finally, orthorexia is not a ICD-10 diagnosis, but basically it's an obsession with healthy eating to the extent that it damages well-being. Of course, it's important to be, conscious of what we eat and our health and exercise, but orthorexia is taking it to a step that can be harmful. And then the difference between orthorexia and an eating disorder is the severity. So people who are orthorexic might eliminate food groups, they might exercise to compensate, they might have intense stress and anxiety when they go to social situations, they might not go to these social situations. So those are all signs, and it's really important that those people get treated so that they don't develop an eating disorder. Okay. So this is what we call our positive nutrition philosophy. And my supervisor, Laura, came up with this, and this is kind of the overarching philosophy that we counsel with. So the first one is all foods fit. So we believe that no food should be avoided, of course, unless you are allergic. And we eat a variety of foods in moderation, mindful about the foods that keep you full and satisfied and make your body feel good. We also always use neutral food language. So never label food as good or bad. Labeling foods as good or bad can lead to guilt. Food has no moral value. Food is just food. You don't have a moral value because you eat a certain type of food or you don't eat a certain type of food. We talk about being an honorable eater. So eating foods that are to honor your body. And how your body feels informs your eating. And that self-worth is not based on number of calories eaten or the number on the scale. Laura always says, don't treat yourself like a dog. So food is not a reward or a treat. When all foods fit, when we allow ourselves to eat all foods all the time, there's a shift in this mindset. So we can eat the cookie because we did something good. We can also eat the cookie because we want the cookie. And then finally, we want to love fat. It's not our foe. We need fat on our bodies and in our food. It's natural, it's healthy, and it's necessary. with all nutrients, we will talk with our clients about the basics. So what's the carb, what's the fat, what's the protein, really objectively. And so with that, that's feared by a lot of our clients. And so when we can talk about it as what is it doing for the body, it can be really helpful for the client to be able to reintroduce it into their diet. I want to talk a little bit about HAES, or Health at Every Size. So this is the kind of movement or philosophy that the goal for health professionals is to help people live healthier and more fulfilling lives by caring for the bodies they presently have. And that a healthy weight is not defined by a BMI, a number on the scale, body fat percentage. That doesn't tell us anything about health. And a healthy weight is the weight at which a person settles as they move toward a more fulfilling and meaningful life. Now, this doesn't mean that everyone is healthy at the weight that they are, but it's really behavior focused. So we talk to our clients about adopting healthy behaviors, and then their weight falls where their weight falls. There is lots of literature that clearly demonstrates improvement in health with little or no weight loss. So diabetics and pre-diabetics who change their behaviors, they'll see an improvement in their blood sugar with no weight loss. And it also comes with the idea that weight cycling isn't healthy. Okay, so I just want to give a little overview of our treatment course. So we get our clients from many resources. So my supervisor, Laura, has been in private practice for 20 years. So she has tons of connections with doctors and other therapists. So we get a lot of word of mouth. I do a ton of networking myself. So I'm always kind of keeping my eyes and ears out for people who I can connect with. When I get a new client, the first thing I do is contact their treatment team. So I'll set up meetings with their therapist, maybe their psychiatrist and their doctors as well. And it's so helpful to work as a team. Most of our clients are seen weekly. In the first session, we'll really take a full history, medical history. We make sure all of our clients get labs. We give them a lab form as well that outlines everything that we like to see. And it's really about getting on the client's page and really understanding where they've been, where they need to go, what their goals are, and setting those goals based on their agenda. And then follow-up sessions will involve increasing their intake. If that's something that they need to do. They may have a weight goal, they may not, depending on where they come in. And we'll do a lot of nutrition education, work on normalizing eating. We'll work on their relationship with food and their body through CBT and DBT. I use an app called Recovery Record, which is a great app that is eating disorder focused. My clients can log their food, their thoughts, and their feelings and their behaviors, and there's no calories or any kind of nutrition info on the app. So they link up with me, and then I'm able to see what they're eating daily. So it's really good accountability too in between our sessions. And then, like I mentioned before, we do meal support therapy with some of our clients. And we move them through this sort of model of structured eating. So this normal eating, making sure that they're eating regularly, 3 meals, 3 snacks, whatever it might be. Then we bring in some mindfulness. So how can we be mindful at our meals? And then move toward a more intuitive eating approach. And then finally, what we call mastered eating. Okay, so I have a couple case studies. So this is client TS. She's a 22-year-old female. She's 5'3". Her weight fluctuates between 117 and 120 pounds. She's celiac disease. She is lactose intolerant. So notice already some diseases of restriction. And she also had a gallbladder attack in December. She came to me with a diagnosis of anorexia, and her goal was to have a healthy relationship with food. Her trigger was in 3rd grade. A kid called her pregnant, and she's also surrounded by diet culture at home. Her family is really entrenched in diet culture. So her labs, when I saw her, she had low vitamin D and B12, has a history of menstrual irregularities, and she had a normal DEXA scan. Her eating disorder symptoms include many restrictive thoughts and behaviors. She won't eat before noon, many fear foods. She's definitely a perfectionist. Fear of weight gain. She counts calories and she purges with exercise. So I'm happy to open this up. I don't know if anyone has thoughts on maybe what the first step would be, or if you have any questions about the case or questions that you would ask the clients. A lot of the work we do is being curious and always asking, 2 to 3 questions for every statement that the client says. So I'll open it up if anyone has any thoughts. Should I keep going?
Yeah, I think you can keep going.
That's fine. Okay, so first thing I did when I saw her labs, I made sure she was taking a vitamin D supplement, and she did get a B12 injection. So we created a meal structure. So we gave a few options for breakfast, lunch, and dinner, and snacks. So she was working on following that. She did start to eat oatmeal for breakfast. She said to me once that she kind of conquered this idea that she couldn't eat before noon. So started eating breakfast, oatmeal. Maybe she had a smoothie sometimes in the morning, even coffee, which she wasn't even doing before. And she's using olive oil to roast her vegetables rather than the spray. And she's noticing that her vegetables taste a lot better. Grocery shopping and meal planning is a lot of work that I've been doing with her. She didn't like doing a full grocery shopping and having a lot of food in her house. She also was really afraid to spend money on food. We call this financial anorexia. Our clients can't do this. They have to spend money on food. And when we started coming up with a grocery list, she had all these condiments she wanted to buy, mustard and barbecue sauce, and she's using them and noticing that her food tastes so much better. It has so much flavor. She's making like maple mustard salmon now rather than just like plain salmon. And we're doing a lot of CBT around the food. If we notice her height and her weight, right, it's normal. We didn't really have an urgency to increase her weight. So we really focus on feeding the body enough to function optimally, to fuel the metabolism, and to make food one part of her life rather than her whole life. When you're not eating enough, right, you're focusing so much on that food. I always tell my clients, like, what happens when someone tells you to not think of a pink elephant, right? You're going to think of a pink elephant. So of course, if you're not fueling yourself and you have all these rules about food, that's all you're going to be fixating on. Next steps with her, we're working on adding in lunch because she hasn't really been doing that, and then adding more flavor and variety, and then a lot of self-compassion too. She's very hard on herself and her body. Second case, my client AJ, 16-year-old female. She's 5'1". She weighs 150 pounds, and she has type 1 diabetes. When she came to me, she has anorexia and a previous history of diabulimia. So she would skip her insulin in order to lose weight. she struggles a lot with body image and wanting to lose weight. Trigger for her, she was a competitive gymnast since she was 12. In these types of sports where there's kind of like this aesthetic pressure, there's a lot of focus on the body. And she told me like her coaches would make comments around food. I'm pretty sure her quote was that they're crazy about food. A little bit of background on her. I started seeing her in December. I saw her for a few visits, and then I got an email from her mom that she was having suicidal ideation and she was in the hospital. Then she ended up going to treatment to a higher level of care. So she was in a residential program, stepped down to a partial hospitalization program, then to an intensive outpatient program, and then she came back to me. And she's doing so much better now. Her A1C is 10.1, and she has a normal DEXA scan. Little background on her diabetes. So she's on an insulin pump, and she has a continuous glucose monitor. So at breakfast and lunch and dinner, she has her insulin to carb ratio. She's doing amazing at counting her carbs. And then she does 23 units of Tresiba overnight. She used to skip her insulin and purge. She doesn't do that anymore, but she has strong urges to restrict. Treatment plan for AJ, completing 100% of her meal plan. So she got this meal plan when she was in treatment, and then I've been helping her to complete it in the outpatient world now that she's back at home. She's not skipping her insulin or restricting her meals. So she has thoughts of restriction, but she doesn't act on these thoughts. We work on meal ideas to increase the variety in her diet and balance her blood sugars, do a lot of CBT around her food and body. Because body image is a big struggle for her, I have a lot of fun tools that I do, and activities that I work on with clients if they're receptive to that. So I have some great workbooks, the body image workbook, the intuitive eating workbook, and we work on a lot of self-compassion too. And her quote, her motivation, what she said to me was, "I don't want to live my life in and out of treatment centers." And that was in response to kind of motivation and restriction. The not acting on the restriction is I want to be a normal 16-year-old. Okay. A little bit about how my work impacts my personal life. Burnout obviously is really high in healthcare professions, unfortunately. I find that I get really emotionally exhausted from this work. Sometimes at the end of the week, I'm just like exhausted. And so I'm lucky that I do feel that I have some work-life balance. Working from home certainly helps with that in a lot of ways. And I recognize, again, that that's a privilege. I had a supervisor once too who spoke about kind of stepping in and out of roles. Sometimes I feel that I'm always a dietitian. And so maybe I step out of my dietitian role when I'm eating dinner with my husband. I also decided, like this year actually, like I wanted to be serious about something that wasn't work. So I got really serious about running. So that's like another outlet for me. So then I can like take off the dietitian hat for a little bit. Setting boundaries is really important. So like sometimes I have to set boundaries with my clients. If they text me at 9 p.m. on a Friday, which has happened before, I might not respond. And I have to set boundaries with my colleagues too. I'll usually respond to an email at almost any time, but you kind of do what's best for you in that moment. Especially with private practice too, right? Like you're on call all the time. I try to say yes to opportunities that excite me. If something, I will turn down things that just like I might not have time for. I don't want to expend my energy into that if it's not going to be beneficial, or it's not going to be fun for me. And so then I also make sure that I do things for myself. I go for a run. I do yoga. I eat. Right. I feed people. I have to feed myself too. My own self-care. And then I make sure that I spend time with family and friends. And I always like to say it's really important to recognize that, find small things for self-care. People talk about self-care a lot as like, go to the spa, get your nails done. It doesn't have to be something time-consuming or expensive either. It can be really small things that you can just kind of integrate as part of your day, even if it's 5 minutes that you kind of like put your head down on your desk or take a break or get outside. Okay, and just we're good on time. Just some overall tips. If you're interested in nutrition, or want always learn more about nutrition. One of the reasons I became a dietitian, for many reasons. One was because it's so applicable to everybody. We all got to eat. We all got to know what's in our food. So learn more about nutrition. Shadow a dietitian or talk to a dietitian. There's a lot of resources I could have given you, but my top two, to learn a little bit more about what I do, reading Intuitive Eating by Evelyn Tribole and Elise Resch gives kind of a really good overview of the philosophy that I come from. And then Sick Enough by Jennifer Gaudiani is a really good background on eating disorders from a medical perspective. And I say love your dietitian here. So wherever you work one day, talk to your dietitian, use your dietitian, refer patients to your dietitian. We're not the food police. We're here to help. A lot of patients are scared to come to us because they're afraid we'll take away all their food. That's not the case. So really make sure to use that resource. While I have an audience of current or future healthcare professionals, I will say, don't tell your patients to lose weight. Weight stigma is a risk factor for metabolic syndrome independent of body size and puts people at risk for eating disorders. So ask your patients questions before judging them or assuming what's going on in their life. This could lead to a lot of healthcare avoidance too, which we don't want. And always work as a team. The doctors and therapists and other professionals who I work with, when they're working with me as a team, care is absolutely improved. It makes my life great. It makes the care for the patient great. So, always, we can really always learn from each other. And I think that is what is so great. One thing that's so great about healthcare. And that is all I got. So I can answer a bunch of these questions now, and feel free to put others in the chat. Okay, so let me scroll through all these questions. Okay, I answered some of these. Methods or technologies do you use to communicate effectively with your patients? So I mentioned Recovery Record, the app, and then, mostly text and email right now. We also do have a patient portal through our practice. Apart from altering the diet, what else would you recommend for those with eating disorders? So this is a really good question. Hopefully I went through this a little bit, but our approach is really holistic, right? So we're looking at the food, but we're also looking at the thoughts and the feelings and the behaviors around the food, the mindfulness, body image, movement. So a lot of people have a really bad relationship with exercise. So, maybe if they're over exercising, maybe we try to work in some gentle exercise, some yoga, some stretching, right? How can that count as exercise too? And how does that make your body feel? So we're really tackling it from a lot of angles. People are, people kind of don't want to sit with their discomfort. So sometimes it's just sitting with the client in session and like recognizing that this might be uncomfortable, but we got to do it. How do you encourage a patient to continue a meal plan when they feel like giving up? This is a good question. So we'll go back to motivation. We'll talk about ways to make the food easier. So while mindfulness is important, maybe watching a TV show while eating, having a distraction, maybe that's going to be more helpful. And that's okay. Maybe it's eating with a family member or Zooming with a friend, right? In this COVID world, it's been really, really hard for a lot of people with eating disorders. So, finding that connection in some more creative ways. Okay, that's some good questions. So what made you want to become a dietitian? So I think I mentioned it a little bit, but I can go more into that. So I wanted to be a dietitian since I was in high school. I always loved food, and I always loved health and the human body, and I knew I didn't want to be a chef and I didn't want to be a doctor. So nutrition was the perfect combination. And then I also struggled myself with some disordered eating. And so for many years, that's like felt like another life, and I like didn't really think about it. And then I kind of got more interested, and it came back to me in a healthy way, right? And I wanted to help these people. What's the difference between a dietitian and nutritionist? Great question. So I had that other slide where with all the requirements to become a dietitian. That's how you become a dietitian. You have to do the accredited program, you have to do the supervised practice, and you sit for an exam. A nutritionist can take the undergrad courses or the master's degree. They could take an online course, and they could be called a nutritionist. So they're not as qualified. They don't have that science evidence-based background like we do. So it's a challenge because people don't know this. So thank you for asking this question. So you really want to make sure that you're seeing a registered dietitian. How competitive is it to get into the field? So our dietetic internship is a match, just like it is for residency. And it's a 50% match rate in the country. At least it was when I'm matched. There's not a lot of spots, and I think that's really the problem. If there were more spots, this would be better. So it's relatively competitive. However, all my colleagues have either matched the first time. If they haven't matched the first time, they've matched the second time. So it just might take a little bit of perseverance. What was the coursework like, and how many science courses were there? Lots of science. I think I mentioned, biochem, orgo, biochem, and then a lot of our nutrition courses are heavy science. And then, so the only thing we didn't take basically was physics, but everything else. And then plus the nutrition courses. But then we also got to take a really fun cooking class. And of course, this depends on where you go to school. What was your internship like? How long was it? So it's a year program. It's broken up into a clinical rotation, a community rotation, and a food service rotation. So the clinical rotation will be at a hospital, typically, right? You're doing a lot of that inpatient nutrition work. My community rotation was at an outpatient clinic in the Bronx. So I worked with a low-income population. That's where I got really interested in working with a low-income population and with diabetes, because it's very common. And then my food service rotation was kind of lumped into that. That's not always the case everywhere you go. What are some other settings you can work in apart from a hospital? Great question. So obviously I'm in private practice. Now there's a lot of remote positions as well. So a lot of these telehealth companies have dietitians on their staff. You can work for a food service company, which seems like a really cool job. So like, I don't, brands that come to mind are like Bonza pasta or Siggy's yogurt, right? They all have dietitians who work for them. Kind Bar has dietitians. So if, you know, kind of a more food servicey realm, you can do marketing and media, a lot of dietitians in that area as well. How has COVID affected your job? So when I was working at the hospital, I left in August. When I was working at the hospital, I was working from home for a few months. Then I went back in person. So obviously telehealth has become huge. Reimbursement by insurance companies increased, now it's decreasing. And then when I made the transition to private practice, unfortunately, right, COVID has really impacted people with eating disorders. So we're busy, we're getting a lot of clients. So professionally, like, COVID has helped me, which I feel guilty about all the time, because there's so many people struggling. But I try to give back when I can too. But yeah, it's definitely, obviously, you know, COVID has affected dietitians greatly, whether it's, you know, people working from home, figuring out how to navigate that, when a lot of clients like really do need to be seen in person too. Do you need some communicating techniques to make patients accept diet plans you make for them? So the first thing I'll say is it's always collaborative. It's not that I'm giving them a plan and telling them, you know, go home and do this. We're doing it as a team. But I absolutely use motivational interviewing. You know, that's a big part of the therapy. So it's really the language that you use is definitely important. How do you customize? Am I okay, by the way? I'm fine on time, right? Okay. How do you customize diet plans for people with eating disorders? So overall, kind of in general, I always say a meal has to have a protein, a carb, and a fat, and a snack has to have 2 out of the 3. We also might use what's called the exchanges, where we might give more specific portion sizes. So like, for example, 1 grain exchange is half a cup. So I might say, okay, with lunch, you need to have 2 grains. So you need a cup of rice or 2 pieces of bread, whatever that might be. When setting up meal plans for patients, what other specialties do you work closely with? So I certainly work very closely with therapists. I don't know if I work with them specifically on meal plans. However, I will share, I make meal plans a lot in Google Docs, so I'll share it with the team so that they can kind of see what the client is working on so that they can follow up and support them in completing the meal plan too. Has seeing patients impacted you or changed your perspective as you started this career? I'm not exactly sure what the question is asking, but you know, has seeing these types of patients impacted me? Absolutely. I feel, and I mean, I think we all go into healthcare, right? Because we want to help people. We're already compassionate people at baseline. But working with eating disorders has changed my perspective in so many ways. I feel like I'm always thinking about like, what is that person going through, right? You can't judge a person based on what they look like, based on what they say to you. You have no idea what's going on with them. So that's definitely been something that I've learned, and kind of taking away that judgment and biases, right? We all have them. but also recognizing that we have them and being aware. Do you still see yourself working in this position 10 or 20 years from now? I do. And one reason that I wanted to do what I do is because I know I can always do it. So like, you know, I don't have kids right now, but when I do, right, I can always have this career. I can, and you know, I can have the flexibility. I can work as much or as little as I want. But I wanted to have a career that I can do forever. And I'm lucky that I do like what I do. So we'll see if things change, but for now, yeah, I do see myself doing this for a long time. Do you also act as a therapist to patients because food is related to emotions? Absolutely. There's a lot of times where I feel like the therapist, there's definitely a line that, you know, I don't cross, or I'll be like, you know, bring this to your therapist, or I'll email the therapist and say, you know, client brought up this, can you address this with them in your next session? So yeah, it's absolutely very closely related, which I really like that part of it. I like the psychology aspect of it. What protocol is established to deal with patients that may have eating disorders caused by some form of abuse? Yeah, really good question. So the nutrition stays the same. We might have, you know, the therapy part might be a little bit different. I mean, I know I have a client right now who she has history of sexual trauma. She's been dealing with her eating disorder for years. She's been in therapy for years. She just started working with a specific trauma therapist. And so speaking with that therapist, right, the therapist really thinks that her eating disorder symptoms will decrease as this trauma is worked through more. So it's really interesting to see how that works. And then again, working with a therapist is so helpful. I also just took a course on eating disorders and trauma. So that was really helpful in, you know, skills to ground the client, right? You know, and ways to make the food easier, and you know, movement, and you know, like I said before, like if they're over exercising, right, which is a trauma response, what can we do to decrease that and make it a little bit safer for them? So yeah, it's absolutely a little bit different for when you have clients with trauma or abuse. Those are all the questions. Are there any others coming in?
Looks like that's about it. But yeah, thank you so much. That was a lot of really great information. I feel like it's like important to definitely talk about this stuff because people don't really understand like the connections to make between all of these disorders and like how they're treated and all of that. So I think it's like this was definitely very informational. So thank you so much for all of that.
I hope I didn't go too fast.
No, you're totally fine. That was perfect. And for everyone who's still watching, make sure to complete the Google Forms by 8:45 to get your shadowing hours. But yeah, thank you so much.